It's taking me. Alright, so Johanna will be here in a second. Johanna is the president. I'm vice president. I'm demoted. But I'll start the meeting off by saying that who was at the gala? Yeah, dude, everybody.
Nice.
That's awesome. And our class, year 3, third years, right? Won the contest.
Yeah.
So, the contest was whichever class would get the most people at the gala would get $200 put into the class account, right? And I don't know what that money's used for at the end, but party. Yes, we're on party. So awesome. Thanks for coming. We definitely made our money back, I think. So that's definitely, I think. So today we're doing a recap meeting for the trip that was 2 weeks ago. We usually have them the Monday after the weekend, but we had MLK Day last Monday. So we'll let the trip coordinators come up and start the discussion. Where is Rebecca? Right. All right, come up. Your trip coordinators, Emmy and Lana and Rebecca.
Yay.
We'll start off by giving you some statistics on that trip. How does this work?
All right, so we only had 3 doctors on this trip, but we were still able to see a lot of patients. So we had 3 doctors, 22 volunteers, 1 U of A translator, and so we got to see 35 patients total. 22 were follow-up, and 13 were new. Which having 13 new patients, that's a lot of work, and so it was amazing that we got to see so many.
Probably the most exciting thing was that by either 8 or 9 a.m. there were 55 names on the list, and we had to actually have them stop signing up. So that means that the word is getting out into the community, and that they're really responsive to us coming down there, and they really appreciate it. So that was really exciting on my end. And we're happy.
So who was on that trip? Just show of hands. Who went to that trip? Okay. I wasn't there.
Well, one of the doctors, Dr. Tavares, was actually downstairs, and she didn't supervise any, and she did amazing. It was her first time going, and she's really up for going multiple times after this as well. And it was just a really good group. Everybody was really cohesive, and the flow was amazing.
Yeah.
Anybody that was their first timer that's here? Yay! Yay! Do you want to say something about the experience? Testimony?
About the experience? It was a really great experience. For me, what I've been actually told my classmates was that I equated that one day to 12 weeks in the clinic.
Yeah.
12 weeks of in the clinic, one day down there, and you see so much more. And so it really does help you develop your clinical thinking skills. So the group is so wonderful, so it's a real safe environment. I screw up as the first time, and they're like, okay, this one, maybe just do it this way. So, you just learn as you go, and I really enjoyed that. Everybody was so helpful and patient.
How many patients did you see?
I actually saw 4 new patients in a row.
Different pace, right? Because you're like back to back versus
they were like complicated, like an hour and a half. So I did 13. I was like, whatever. It was like 8:30 if I stopped.
At night. So
yes.
it was a 13-hour day, right?
It was the longest.
Every time I go into the medicinary to get something, I thought, oh, people are eating it. It's like, and I go back, I already had a patient waiting. I mean, like the guys would have it my first time. Where I had three people, it was a daughter, 2 daughters, and a mom come in, and all new patients at once. So I had to do an intake on it. Yeah, so nothing like, but it was good. Everybody was so kind. Can't wait to go back.
Any other feedback from any other volunteers that were here? No? All right.
The whole trip seemed really cohesively. Everything ran really smoothly. I don't think, out of the 3 trips that I've been on, I don't think I've ever experienced one quite like this, where people were literally able to rotate to every position. So I think it was unique in that experience that everybody got to try and learn new positions, so that when you go back, you have a better chance of teaching other people, or at least better knowing what you're doing. But that was pretty special.
What's the next slide on it?
It's not
Joe
good.
Martin's case.
Oh.
We
I didn't
passed
want
it.
Just skip,
We
go
to
through
Kumar.
that.
Yeah, Kumar won.
He's number 2, right?
And then Zandy.
Okay,
or-
cool. So now we're gonna let some of the primaries. Kumar, you want to start?
Yeah.
Do you want to come up here? Because we're taking a video, so we want to see your
I wore my white coat specifically for this meeting. So I had 5 people. I saw 5 people. 2 of them were new patients. This was my last patient of the day. She was a 57-year-old female. This is not her, but it was an image I found on Google. I thought it was fitting. It's a little Indian woman. Returning to clinic after 2 years. So she saw us once in 2011, which I've never seen a chart go that far back, and then them visiting again. So this was her second visit ever. She was presenting with unilateral shoulder pain and epigastric pain. And Michael actually did the intake, and it seemed like her shoulder pain was her main concern, and then like towards the end of her interview, it was her epigastric pain that was like really severe, and she was like, this is what I want to get taken care of. So it's kind of funny how they present and they tell you different things afterwards after you do a full intake. So continuing, she reported sleeping on that shoulder like all her life. I was trying to rule out anything severe, and it literally just started like 2-3 weeks ago, and it just started like hurting. And so it was kind of interesting how that came about. And then treatment-wise, like we treated her a long time ago, so whatever we treated her with in 2011, that was all done with. So she came in for this epigastric pain. So on physical exam, I didn't find anything pertinent. I don't remember her vitals, but it wasn't anything that stood out. And then range of motion on her left shoulder, which was the shoulder that was bothering her, it was decreased. So I was thinking more of a muscle thing, so we looked at her deltoid. And there were no signs of nerve damage. And on abdominal exam, there was tenderness to palpation, pretty much in all her upper quadrants, and she was just in a lot of pain. And we actually palpated a hernia, and Dr. Retz was my supervising physician, so she helped me kind of feel it out, because I haven't palpated many hiatal hernias, and so it was nice to be down on this trip to actually be able to do that. We actually learned a hiatal hernia release in phys med with Dr. Nick, so I was able to do that, and we did it like twice just to make sure. And then we gave her these instructions to do these heel drops, so she kind of just like does like really, really hard, and like 20 of these when she wakes up every morning, which kind of just pushes everything down. So we wanted to rule out anything like tendonitis, bursitis for her shoulder, any impingement. Abdominal, we want to rule out like gastritis, GERD, peptic ulcer, hernia, which is what she had, I guess. And we diagnosed her with a strained deltoid muscle and hiatal hernia. And we treated her with homeopathic sulfur 30C. We did like a mini homeo intake, so she was feeling like a burning sensation going upwards. So she had like a hot face, and when she slept, big keynote was when she uncovered her feet. She had her feet uncovered, but everything else was covered. So that's a big keynote to sulfur. We gave her some licorice and probiotics to kind of help her gut out. Don't sleep on the affected shoulder. We gave her a muscle support or a muscle supplement for inflammation. Castor oil topical massage over stomach and shoulder as needed for pain. And then fish oil for inflammation. And we told her to come back, so hopefully she'll probably come back. They're pretty compliant, so. I'm sure she'll be feeling better in no time. And that's me.
Cool. Thanks, Kumar. Any questions for Kumar? Yeah?
I have to get going.
All right,
Yeah, and I
thanks,
have
man.
Gonna go fast.
So as I shared, it was my first time as well down there, and then right off the bat, there was a mom and 2 twins that came in. And it was not the case that I'm going to share with you because I couldn't remember all the stuff 2 weeks ago. But interesting because they were identical twins, and so one was had the symptoms, and then the other twin would experience them in a physical way. So it was interesting to see, and the mom shared with different things. So the one twin was sick, and the other one, the mom just wanted to make sure she wasn't going to come down, so she was actually healthy. So they took him else day, and then I got, after that, then they were saying, oh, there's a lot of flu and colds, and so then I got an 18-year-old came in. She was a typical 18-year-old. She was slightly overweight, and her chief complaint when she came in was just nasal congestion and a very bad sore throat that was keeping her from sleeping. And so we thought that was going to be a quick in and out, we could give her some botanicals, some tincture. And Dr. Retz was also my supervising doc. But during the intake, she then said she was experiencing some lower right abdominal pain. And then she handed me she then said she'd been to the ER 3 days prior to that, and they had just sent her home with nothing, no treatment. Just so they'd gone and it was a wasted, and she handed me, she did have a CBC and a UA. So I'm reading the CBC and I'm thinking, am I reading this right? So Dr. Rez came over, and what happened was, I don't know, see if you guys can figure out. It was actually those lab results that set us down. She reported during it that she had the sad Mexican diet. She was very high in dairy and sugars and low protein. So I was going, a lot of that, she'd had this nasal congestion for a long time. It wasn't like something that was new. So I, right away I'm thinking if she just give up her dairy and sugars, those symptoms would probably improve. She was sexually active, and that will be important soon. She reported not taking any medications, and her last menstrual period was in October. And since then, though, she would say there were scanty periods with some spotting as earlier as 2 weeks prior to being at the clinic, so it's been real recent. So on physical exam, there was nothing. The vitals were normal, and the ADT, her ears and her eyes, but her sinuses she had, they were tender here. She complained of tenderness in her posterior lymph nodes, but then there was no lymphadenopathy. But her nose was very boggy for the terminates, and it was red, so it was nice to see that, because we don't see that all the time in the clinic, to see someone that was very chronic. And then when I did her throat exam, one tonsil was large. I mean, even though we said 2 and 3, but her right tonsil was was really inflamed. It had like a little blister kind of at the end, a little pustule, but not the right white exudates. And you can see the postnasal drip coming down. And then we did the abdominal, and she had this tenderness in the lower right quadrant that she yelped when I was doing compression and palpation. So then I looked at her lab results, and there was this positive pregnancy. So
and she didn't know that.
She thought, but the hospital didn't really explain to her. So it was like, then we say, you're pregnant. She was like, no, I've had my periods. The scan. Well, that's when can you explain your periods? So we did the timeline and found that it was just spotting. So that was the concern of Dr. Retz and mine was then if she's 3 months pregnant, why is she still spotting? So, and then we were like, we can't really give her anything. We're thinking here she has this nasal congestion and everything. So now everything that we have in our toolbox to really use, we can't. Like for botanicals. So what we did, and then we sent her for labs, even though she just had it. She was borderline anemic. I don't remember the results. I'm sorry, guys. I don't remember. But it just was like the beginning. I mean, it was like, is she anemic or not? But based on her diet, her tiredness, and having that. So that's the approach we decided to tackle the anemia, increase her protein, get her to decrease her dairy and sugar intake. And we diagnosed her, with not knowing, is it appendicitis, ectopic pregnancy, ovarian cyst, pelvic inflammatory disease. We wanted a transvaginal ultrasound, but they couldn't afford it. And the machine is broken, and it's been broken for 3 months. So that's why we're unable to get one even done through the clinic.
Do we have one?
Well, Phil, right? That's his name. He said, yeah, he could, but it had been broken for 3 months.
So the doctor that we work with
Dr. Gonzalez.
Yeah, Gonzalez.
Yeah, so she would have to go somewhere else, and it was too expensive.
So did Dr. Gonzalez cover it then?
Yeah, it's just not working.
It's broken. It's broken. It's broken. So what do we do with this patient? She's miserable. She can't sleep. She's 18 years old. She just found out she's pregnant. She wasn't married. Go into the details. So what we decided to do is treat the symptoms. So we showed her how to do an inhalation steam bath. We had some doTERRA breath, which is an essential oil, and have her do that 5 to 10 minutes to see if we could break up the congestion. The neti pot, again, just kind of get to decrease that inflammation, and some Gaia warming rub. We gave her some of that. She really liked that. It was all just kind of soothing for her. For the lower right quadrant, we showed her how to do a castor oil pack to see if that, why is she having it? We don't know, but we thought she's having just some sort of inflammation, maybe from the pregnancy. I don't think it's ectopic because she's 3 months pregnant, or then I think it would have manifested in a much different way. It's usually a lot sooner. She would have had a lot worse symptoms. We gave her a probiotic, because of the, getting her to reduce her diet, her dairy and the sugars, improve her gut health. A multivitamin, that's the only one in the clinic we could find that had iron in it. So that was the choice for that. And then vitamin C to help with her immune system. And then in the pain, she was told if it persisted, to go get an ultrasound in 1 week and return to the clinic. So, I don't know where she's at. Well, maybe she'll come back and you guys will see her.
Any questions?
Any questions?
Are all the treatments, are they free or are they reduced? Or?
No, they're free. So when you go down there, there's a medicinary that these wonderful medicinary folks do, and there's like all of them that we all carry down there in our cars and our bags, and that was kind of a learning experience for me. So if you decide to go, leave your bag empty because we're going to fill it with supplements to get across the border. And so whatever's there is what you have to work with that day.
I'm surprised by the heat with the castor oil.
That's Dr. Retz.
Really?
Which I was surprised as well.
What, over the abdomen?
Yeah, over the lower. So the lower left and right, but mainly the right.
Are you not supposed to do castor oil when you're pregnant?
No, you can do it. I think she was saying the heat, not knowing.
Yeah, usually with hydro, it's kind of toned down during pregnancy.
Oh, okay.
So I don't know if she was because of the inflammation.
Yeah, it helps drive it in, right?
Maybe because she was a fairly large girl. Could that have made? You have to ask her. Any other questions?
Okay.
Yes.
Do you typically, does the clinic do a lot of prenatal care?
No. My question was too, do we do pelvics on this? And Dr. Red said yes, but if it's warranted, but they don't do very many.
So would a patient like this continue to come monthly for checkup?
She was told, we didn't know we were going back in February, so she was told she was given enough supplements for 2 months and to return to the clinic. And so this was her 3rd visit to the clinic. I do remember that, but she hadn't been since like 2012. So.
Anybody else? All right, thanks, Danny. She got a lot of stuff though, huh?
Huh?
She got a lot. It's a lot of treatment. She got a full.
Yeah,
treatment.
she did. As much as we could with the pregnancy.
Who's that? Oh, I gotta do this.
Yeah, Kristen's trapped on shift.
You can come up there, Johanna, if you're ready.
Okay. Maybe she'll show up. I don't think she's gonna make it given the patient she was on. I don't think she's gonna make it.
Alright, it's okay. We'll do you and then do some other announcements and stuff.
Okay. So I'm just talk about one of my patients. So this patient was a 34-year-old female that presented to clinic for follow-up. 64-year-old female that presented to clinic for follow-up on an open wound, as you can see right there, and hypertension. She was first seen 2 months prior where the wound had been debrided by us, and she was placed on hypertension medication. So we placed her on pharmaceuticals for a 30-day period. Her blood pressure when she first presented was about in the 200s. I believe it was like 210 over like 90 something. So it was really high blood pressure. The wound, this is actually right before we cleaned it, but it looks a lot better than it did previously. Before it was very encrusted, it was very swollen, it had a lot of red and swelling around the edges of the ulcer, so we were happy with the improvement. Also, her blood pressure had significantly come down since the first time that we had seen her. When I saw her, it was like 148 over 72 versus the 210 when she first came in. And we think that the hypertension was greatly contributing to the wound getting worse.
Question. Is this the same patient that Sabrina had?
Yes. Yes. It looks way different, doesn't it?
What caused this?
She's had this wound for about 10 years. So it was our understanding that she had a varice that ruptured and then became an open wound that never healed and then turned into an open sore like this. So a varicose vein that just ruptured. So she presented for the clinic to not only get this cleaned out, but she also had a new complaint of 10 to 5 minute episodes of tinnitus only in her left ear, once or twice a week when she woke up in the middle of the night to go to the restroom. She was also having muscle spasms on the right side of her neck, but the patient denied blurred vision, dizziness, headache, nausea, vomiting, or trauma. Does anybody know why you would ask those questions immediately when someone has tinnitus? Like, what are we trying to like rule out when we ask those questions? Yeah, so yeah, these symptoms would be associated with, like, if she was having a space-occupying lesion like Bryce said, or also a hypertensive crisis. So in this particular circumstance, she had a history of a very high blood pressure, and if that spikes, like if she stopped taking the blood pressure medication very rapidly, her blood pressure could spike all of a sudden, and that can cause tinnitus, but it usually would come with like blurred vision, dizziness, not possible nausea and vomiting. So that's why we ask those questions. Okay, so life habits. The patient only cleans the wound about once a week with water and sterile soap. Someone from the church is a paramedic and he brings her gauze and bandages and sterile soap to clean the wound, but she's not very compliant. She's supposed to clean it every 24 to 48 hours, especially when she's been like walking on the streets because it collects a lot of debris. But she's only been cleaning it about once a week, and she has no one to help her clean it as well. There's no one at home that helps her clean it. So the wound is open and moist all the time. She never covers it, and it tends to pick up debris when she's walking around and doesn't clean it at the end of the day. Patient was not compliant with the diet and water intake, so we made suggestions previously about her modifying her diet to help the wound heal, and she was only drinking about 8 ounces of water a day, which is really, really low, and is not good for her condition. So she was not compliant with that at all, but she was compliant with taking the supplements and the hypertension medications that we prescribed her, which seemed to have greatly helped. Okay. Physical exam. Patient had no fever. Her blood pressure today was 149 over 72 when it had previously been in the 210s. She had a subluxation of C3, C6, T5, T8, T9, and T10. Both ears were completely compacted with cerumen all the way to the tip of the scope. So I was looking in her ears, and when I first stuck the scope in, it was completely black, and I thought that I had forgotten to turn my scope off. So I pulled it out, realized my scope was on, and then I looked at the other end and realized that there was cerumen packed into the scope that like enters into the ear. So I replaced it and re-looked in the ear and realized that there was cerumen like all the way to the edge of the ear canal. Like, I'd never seen such an impacted ear. It's actually much worse than in the picture here. I just pulled this off the internet. But if you can imagine, like, the dark, like, starting here. Like, it just looked like a wall of, like, dark brown. I looked in both of her ears. Cardio and pulmonary exam was unremarkable and normal. Right, so based on the physical exams and her presentation, why do you think that she was having the tinnitus? Keep in mind that she was only having it about once or twice a week at night. Does anyone?
She lays down.
Say it again?
Her hypertension. Worsening. She moves around.
It's something to consider. But if she was having hypertension crisis, it would be more likely to occur during the day when she's exercising or doing something that would increase her heart rate, cardiac output. She's in a parasympathetic state when she's sleeping. Her blood pressure is most likely to be the lowest at that time. So any other suggestions of why?
Maybe she has subluxation.
Yes. So the two main causes is she's only having ipsilateral tinnitus in one ear, muscle spasming on the opposite side of her neck, and she has several subluxations. So the most likely cause of her tinnitus is the subluxations and the muscle spasms. Also, the cerumen in the ear probably isn't helping the situation as well. So for treatment, we first did a thoracic and cervical manipulation. Then we irrigated the ear to remove the impacted cerumen. So the way that you do this is you make a solution that's 1-to-1, half water and half hydrogen peroxide. If you have access to a way to heat it up, which we don't in Mexico, it's nice to have it warm to about room temperature. So you can put it in the microwave or heat it up on a stove, whatever you want to do to get it about room temperature to make it a little bit more comfortable, but it's okay to do it at room temperature if you don't. What it does is it bubbles and it breaks apart the cerumen and actually dissolves it. So you have the patient lay on their side, you pour a small amount till you can see the water line in the ear. You let them lay there for 45 seconds to a minute, and then you have them turn their head like this and drain the ear. And you can actually see that the draining fluid is like a light yellow color, and that's telling you that it's dissolving. And you just keep repeating. So what I do to be most efficient is I have the patient lay back and I'll do one ear, and then I'll flip them, and while that ear's draining, I'll be putting fluid in the other ear. It's just, it saves time. We had to do about 6 to 8. I think one side I had to do it 6 times to get all the way down to the tympanic membrane, and the other side I had to do it 8 times. When you do this, just keep in mind to explain to the patient that it shouldn't hurt. If it hurts, you immediately need to stop, because that means that there's a tympanic membrane perforation, which means that the water and the hydrogen peroxide is actually getting in the middle ear. So as soon as you stick it in someone's ear and they're like, ah, you need to stop and reassess the ear to see if there's a perforation. The only other reason that it would be that painful is if there's an acute infection, but you should be able to see that on the wall when you are first assessing the ear. Also, you can explain to the patient that if you've ever had hydrogen peroxide on your skin, it bubbles, right? So if you can imagine that against your tympanic membrane, it does make noise and it tickles. So it's a little uncomfortable for patients, but it shouldn't hurt. We clean the leg wound with sterile water in a 1 to 50, and that's a very small amount, of Golden Seal and sterile water. So I just put a little bit of Golden Seal and then fill the rest with sterile water. I clean the wound out by irrigating it and then dabbing it dry with sterile gauze. We then had a medicated zinc oxide roller gauze. Zinc oxide is a medication that we use in the United States. It's a prescription medication that is used for class 2, like stage 2 and stage 3 burns, and also like leg ulcers or bed ulcers. Anything that's a large, flat, open wound on the body, zinc oxide is the prescription medication. And one of the reasons that we did this is because she doesn't clean it regularly. It needed to be covered. And also we want to try to help this wound dry out and heal up as much as possible. So we went ahead and applied the zinc oxide medicated roller gauze and then sterile roller gauze, and then we wrapped it in an ACE bandage to make sure that there was contact of the ulcer and the zinc oxide gauze. There's a paramedic that works for the mission, and he volunteered to not only get her the supplies to continue doing this and bring her the zinc oxide rolls, but also to go to her house 2 to 3 times a week to clean the wound the same as we did and wrap it. So hopefully we'll see a dramatic difference next time we go down in February. We gave her supplements to support her general health, a multi and a fish oil. We took her off the hypertension meds because currently she had run out like 30 days prior to us seeing her, and her blood pressure was actually being well managed off the drug, so we saw no need to medicate her at that time, so hopefully it will stay down. We gave her a vein blend, which is a botanical blend. Unfortunately, I don't have the chart, so I couldn't tell you exactly what's in it. but that was to improve the integrity of her venous return in her legs because that was one of the causes that actually caused this ulcer to form in the first place. And then we decided that since she is compliant with the medications but wasn't compliant with the dietary recommendations, that instead of just re-emphasizing the dietary, we would just ask her to solely do one thing, the thing that we thought was most important. And in that case, we thought it was water. So we're like, if you do nothing else, if you don't follow any of the dietary recommendations, we need you to at least drink this much water a day. And so I really hope that she's compliant because I think only getting 8 ounces of water a day is really an obstacle to cure for her. So, are there any questions about my case? Yes?
Did you do the vertebral artery test or anything before you tested it?
Yes.
Can you talk about why that's important?
So if it's important to do a vertebral artery test to make sure that there's, well, when you do a general screening exam, which you should do on all patients in Rocky Point, you're also checking for like bruits and the carotid arteries. So when you do adjustments, you want to make sure that their vertebral arteries like aren't obstructed, that you're not going to knock any bruits off in the carotid arteries during the adjustment. Also, in patients that have like hypertension like this, you also want to check for jugular vein distension. I don't know if you guys have learned that physical exam yet, but that will tell you if the person is like in cardiac distress. Someone can be in cardiac distress even if they don't have a really high blood pressure. So this person had a history of high blood pressure. So we still want to do those tests to make sure that her cardiac health is, even though her blood pressure is more regulated, that her heart has an excess strain. And those are all things you want to evaluate before you ever move a bone in someone's neck, especially with how many arteries and nerves we have present there. So, any other questions?
2 questions. Did she have other varicose veins in her legs, and was her blood sugar checked?
Yes. Okay, blood sugar first. Her blood sugar was a non-fasting, and it was 107. Because I was expecting it to be high, and it wasn't. That's why I remember that. So she doesn't have diabetes. She hasn't had a history of diabetes, which is a little surprising considering how bad this wound is, because usually when a wound is like this for this long, usually what's inhibiting from healing up is high blood sugar. But in this case, I think it's the fact that it isn't being cleaned regularly, it's opened all the time, it's not draining properly. What was the other question you asked? I'm sorry.
Did she have other varicose veins in her legs?
Not noticeable varicose veins, no. Her leg that the ulcer is actually on, she actually had 2 ulcers. You can see I'm cleaning one side, and this ulcer is actually on the other side, so she had like 2 that were like on either side of her ankle. And it doesn't appear to have any varicose veins on either side of her leg, but both of her legs are like really thick, kind of crusty skin on both legs. Like when you touch around this wound, and even like the ulcer ends here, but if you touch like up here, her skin is hard. Like you can't even do like tests for edema. You can't even really like push into it. Like it is rough, and it's obvious that her body has adapted to try to protect her legs by like putting on lots of layers of hard skin, like a callus. It feels like a callus on the bottom of your heel. So because of that, you really can't see any veins. It's like a hard cast has developed on the outside of her leg. So she might have some varicose veins underneath that we can't see, but there's none that we can currently assess.
Is water more expensive in Mexico than soda or alcohol?
No, it's just preference. So
I just see like every single patient that I translated for those represented today, they don't drink enough water. So
I thought it was the
it's a
sanitation.
financial issue.
yeah, well, the thing about Mexico water is that it's definitely clean when it goes through the treatment plant. Like, it's safe to drink then. It's just if it gets contaminated in the pipes, because their sewage systems are not as developed. And so, like, that's why Phil at the mission says, don't drink the water here. There are some places that they know for sure that it's safe, and then there's some places where you really can't verify whether it's clean or not. But as far as I know, from the patients I've talked to and I've asked about access, it's not about access, it's about preference. It's the fact that they would rather drink soda or coffee or juice. They just don't like the taste of water because it has no flavor, is the feedback that I've had. So I know that at the church, the mission that we do, they have these blue jugs, and you can just go in there and drink the filtered water. So I don't think it's an issue of access. I think it's an issue of preference. And the other thing is the patients that we're seeing, a lot of them are pretty advanced in diseases. Like this case is obviously, she's in advanced stages of this ulcer. So people that tend to get into these states usually have unhealthy life habits. And so I think another trend to why we are seeing so many people that don't drink enough water is also tied to the fact of why they've come in to begin with. And the people that are drinking enough water aren't necessarily having these major health issues and then aren't needing to be seen by a doctor. So.
In practice, are you allowed to use other methods to clean out the ears, like the candle?
Clinically, we don't ever use the candle. Honestly, the safest way is to irrigate the ear like this because it's safe. There's no way that you can like puncture the eardrum. If you go to an EENT, they have like special tools, like think of like dentist tools, but specifically made for the ear, that they can actually go in and kind of like scoop it out. Like they have a little thing that's like a rod with like a little loop on top, and they stick it in and they twirl it, and it takes the bulk of it out, and then they'll still irrigate it. And they might use a more medicated solution. The hydrogen peroxide in the water is great because the hydrogen peroxide is a little disinfecting, but it's not like we're putting a prescription medication into somebody's ear. So it's widely used. When I was in EMT, that was what we used to irrigate ears on the ambulance. So I mean that's a standard practice.
In the clinic, I really have TRX.
Yeah. Yeah. No, in Mexico we just like I just took like a little spray kind of lotion bottle and mixed it up and then just used it. I mean, you can just use whatever is available. But in general, unless you are really experienced, you don't want to stick anything in the ear canal because you could puncture the eardrums. People are different depths. Like looking in the scope, you can't look in the scope while you're inserting it. You know, it's one of those things where you feel like it's a lot further down than it is, and so it's just more dangerous to do that. So it's better to stick to a solution like that as long as you follow the rule of if they like shout and they say it stings, you stop irrigating. So.
Any other questions?
Would her uncontrolled hypertension have contributed to the first aid?
Yes. Yes. So we don't actually know like the exact etiology of how this formed. Like we just have her story, and it was 10 years ago. And she also has a history of not taking care of the wound that well. So while she's saying that a vein burst, it could like have been any number of things. We don't really know. But that's what she explains to us, and that's what she said the doctors have told her. We have no idea what her health was like 10 years ago as well. If she currently had hypertension, or she had a varices, and then she had trauma, and that opened it up. We have no way of knowing that, but that's a very real possibility that could happen. Any other questions on this patient? No? All right, thanks for being here.
So nice variety of types of cases, huh? So time's almost up, but we have some announcements to make, and I want to make sure we get through them. Oh, here we go. Announcements. Do you guys want to announce the next trip and stuff?
Sure. The next trip is going to be February 8th, and we're doing sign-up starting at 8 a.m. tomorrow through Wednesday at midnight. So if you can go on February 8th, sign up as early as possible so you can increase your chances of getting on the trip. Let's see. I guess. Oh, and you have to be an NWB member in order to go on any trips in the future. So hopefully this is your second meeting, so you're automatically a member. If not, it's $10 for the whole year, or you have to do, 2 hours of community service?
Well, NWB related,
yeah.
Elizabeth will go into it in the next
Okay.
But yeah, that's very important.
Yeah.
Also, it helps if you sign up at 8:01 in the morning. If you can't drive, you can't speak Spanish in your first quarter one or quarter two. It really does matter to get there as early as possible. And you can fill out the application or know the questions that we asked for you to fill in before 8 o'clock, so you can get it ready and then just copy and paste and then submit.
You can actually fill it out, and then when 8:01 hits,
You submit.
So, just a little trick.
And there is now a Rocky Point Trip Scholarship that we've been able to start this quarter, and you just have to apply between the 12th and the 18th of this month, of February, and then you'll have the chance of possibly getting your trip funded. So that's new, and we're excited about it, so apply. And again, you have to be an NWB member to qualify, and Elizabeth will explain how that works.
But if this is your second meeting, or it's your first meeting, make sure to sign the sign-up sheet. Where's the attendance?
Did everybody sign in?
Awesome. So if you haven't signed in, be sure to sign in over there by the end of the meeting today. If it's your second meeting, come up and see me and Alana. We have extra buttons.
Yeah, these are only going to NWB members. It's exclusive. I was passing them out to members only, and whoever wasn't a member they were literally getting mad that I wasn't getting that. I was like, really kidding.
So we only have so many of them, so come and take your fancy new button today if it's your second meeting and you're an official member now. So 2 meetings per quarter, or 2 NWB volunteer meetings per quarter, or you can pay Alana your $10 dues, and that covers you for the year. You want to become a member as soon as possible because it makes you eligible to apply for trips and scholarships. Plus, you get the discount on shirts, and you can run for leadership positions. That'll be the fall quarter.
And the $10 for a year will cover you until this time until January 27th of next year. We'll do by month, right?
Yeah,
so
the beginning of the month.
Beginning of the month, so it'll cover you for an entire, not calendar, or you know what I'm saying, not calendar year, academic year.
12 months
it's
from
year
the time
long.
of purchase.
There you go, perfect. So it's kind of worth it, right? You don't have to deal with us at these meetings. So really quick, in case you haven't met us, it's myself, Johanna, Elena, and Elizabeth as your executive board. Ask us anything if you want have any questions about NWB, or if you want to be more involved in NWB, you can definitely approach us. That's us at the gala, right? Wanted to put up a nice picture. This is the entire board. So ask them for stuff too. Don't just, you can ask anybody for questions that you see up here. So they should know the answers. So anybody else have questions about how to be a member and how to go on trips and stuff like that?
I don't think we mentioned that the scholarship doesn't guarantee your being on the trip.
Right, so the scholarship, you still have to go through the trip application process and be selected, and then you can use your voucher for your free trip. So, and it covers the $50 fee and not the whole, the housing and the food and everything else that still has to come from you. Good.
Any drivers in the last trip give receipts for me? I'm here too. Right now.
Yeah.
You're talking about applying early in the morning. Is that because of the
So the way that the algorithm that we have set up that works the best, that's fair for everybody, is that we accept volunteers based on the need and so that the clinic flows properly. And usually that means that we take primaries first, so we can see the most amount of patients possible. So we need primaries, and then we need secondaries to help those primaries, and then we need
translators before secondary.
And then and Spanish speakers are really needed. Like, we're always low on translators and drivers. So if you are a first year, if you're a quarter one and you can drive and speak Spanish, like, you're in. We need it. Like, we need it for the clinic to function. And if you're a quarter one and you can't drive and you can't speak Spanish, then it's important that you apply at 801, because once we have those required positions that we need filled up, then we go in order of who filled in the application and the time that it came in. Does that make sense?
How often do you have meetings?
So our meetings are usually bi-weekly. That's bi-weekly means every 2 weeks, right?
Yes.
Not this, so we won't have one next week. Huh?
It's bi-monthly.
Bi-monthly. 2 per month. Well, about 2 per month. And that's just so we can have, really put a lot of work into each meeting and have quality meetings for everybody. A lot of, people prepared, for this, and it's hard to do it every week if at this level. So.
The next one's on the 10th. Is that right?
Yeah. So the next one will be on the Monday after the next Rocky Point trip, and then we'll have one on medical Spanish, like a little class on that, and we'll think of some other things and be creative.
You guys haven't liked the Facebook page? There's an NWE SEM Facebook page, and we also post trips, sign-ups. We post what the meeting's going to be over, so you can get these announcements randomly if you don't get them at the meeting or through your email.
Yeah, join the Facebook page. Anything else? Thanks for coming. Did you guys learn something cool, right?
Yes.
Yeah. It was helpful to see some of those things.
Do you have any
I don't know. I have a feeling.
You're gonna what? He's gonna surprise you?
Oh, okay, cool.